Hello and welcome everybody to our discussion tonight on understanding the military culture. Particular welcome to all our participants. We had an astounding over 1,700 people register their interest for this webinar. Now clearly not by any means all of those will come on board. I think at the moment we're up around 560 and growing. So I think that the fact that there's so much interest is a testament to just how important this issue is for clinicians around Australia, and it's fantastic to have you along. Welcome also to those who are watching the podcast later on, and a very warm welcome, of course, to our esteemed panel, who I will introduce in just a minute. Before we get started, I would like to pay our respects to the traditional custodians of the lands on which our presenters and our participants are located. I'd like to pay our respects to their elders, past, present and future, for the memories, the traditions, the culture and the hopes of Indigenous Australia. My name's Mark Creamer, Professor Mark Creamer if you like, and I'm a clinical psychologist. I have a long-standing interest in the mental health effects of trauma, and within that a particular interest in veteran and military mental health. So it's a really great honour and a pleasure for me to be facilitating tonight's webinar, which I'm looking forward very much to, and to working with our esteemed panel members. So I will go on and introduce them. Now, when you registered, you got some bios for each of our panel members. So I won't go through all those details again. I'll just introduce them fairly quickly. But first of all, I'd like to introduce Dr. Duncan Wallace. Duncan is a psychiatrist with the Australian Defence Force in their Centre for Mental Health. Welcome, Duncan.
Good evening, Mark, and good evening to all the participants. Pleasure to be here.
Great to have you, Duncan. I was going to say that psychiatrists are something of a rarity in the ADF, aren't they? Have we ever had a full-time psychiatrist in the ADF?
Perhaps in Vietnam for periods of time, and maybe in World War II, but no, I've done a bit of reserve service in the past, but that's only been on a part-time basis.
Right. It's interesting, yeah. Well, hopefully that will change in the future. I guess that mental health is becoming more and more significant and a greater awareness, so hopefully that'll change. All three of our panelists tonight have considerable experience in the Defence Force, in both reserve and full-time capacities. And because we're talking tonight about the military experience and about military culture, I thought I would ask each of them in their introductions to comment on the highs and the lows, the good bits and the bad bits, as it were, the best and the worst. So I'm going to kick off with you, Duncan, if I could. What would be one of your best memories of your time in the Defence Force, and conversely, one of your worst memories?
The best would certainly be serving as the Chief Health Officer to the UN Peacekeeping Force in East Timor in 2003, and I got to work with UNICEF, and we organised a mass vaccination program for measles for 130,000 Timorese children, so that went extremely well. The worst would have to be participating in the body recovery operation of our 9 deceased shipmates following the terrible crash of Shark 02, a helicopter on Nias Island after an earthquake there in Indonesia in 2005. That was pretty tough.
I can imagine. That does sound very tough indeed. But I'm interested also in the East Timor experience, and you know, we hear over and over again how important it is that our serving men and women can see some value in what they're doing. And East Timor, I think, was a good example where people did feel that they were very valued and so on. And in fact, I think even Tom mentioned, yeah, Tom mentions that in his case. All right, our next panelist is Dr. Stephanie Hudson. She's currently the National Manager of the Veterans and Veterans Families Counselling Service, the VVCS. Welcome, Stephanie.
Hi, Mark. I'll just correct you on that, because I've gone from that role to being the DVA mental health advisor. So, but I do get to work in VVCS regularly. Good.
So you can still talk knowledgeably about it, I'm sure, when the time comes.
Yeah.
I was going to, Steph has a very long, before she moved to the DVA, she has a very long history within the Defence Force in the Psychology Corps. And I was just going to ask you to comment very briefly, Steph, on whether you think that attitudes towards mental health in the military have changed over the last 20 years or so since you joined up.
Mark, I think it's something that's really changed. And for me, the biggest change is the willingness of people to talk about it. I actually get to teach on the joint Warrant Officers course, where we bring together the next generation of senior soldiers, airmen and sailors each year. And I've been doing that for 5 years. And 5 years ago, we talked about mental health and cultural change, and it was me talking to them. Last year, they were telling their own stories. And I think that's really important when people are willing to, senior leadership, to actually stand up and say, look, I've had challenges and these are the challenges I'm facing, and I'm going to lead my boys in a different way.
That is a huge step forward, isn't it? I reckon this is an issue we're going to come back to a few times later tonight, but that's clear evidence that things are moving. So let me ask you the question that I asked Duncan. What about your best and worst moments in the ADF?
Look, the best moment would be serving with other Australians in Baghdad, the chance to help another country and to be there in support of, young Aussies. Probably the most challenging, look, honestly, when you said that, the first thing that came to mind was the worst moment was my farewell dinner at the War Memorial, when military officers do not cry, but I could not help myself because it was really sad, important transition point, but very sad.
Yeah, huge transition, I'm sure. And I'm sure you were allowed to shed a tear, weren't you? I think I shed a tear when I left the centre in Melbourne as well, so I'm sure that's allowed. Okay, thank you, Steph. And our final panel member tonight is Dr. Isaac Seidel. Isaac, hello, Isaac. Isaac's currently a GP and a colonel in the Army Reserve, as you can tell from his uniform and flashing there. Great to have you with us as well, Isaac. Am I right in saying you're based in Canberra as a GP, aren't you? But you've also got an appointment at James Cook University in Townsville, which seems a long way from Canberra.
It is. Look, I guess I'll correct you slightly on that, Mark, in that I'm back in the regular army. When I was in the reserves in the late 2000s, I was up in Townsville, and I became associated with James Cook University School of Public Health in particular, and I had the privilege of teaching on some of their disaster medicine courses. I guess that sort of links to one of my best experiences, and one of the themes that you'll always get when you talk to defence people is our best experiences are our deployments. It's where the rubber hits the road. But in my case, my one of the ones that I will always remember is my deployment to Pakistan after their earthquake in 2005, where we had the opportunity to touch the lives of many people after that horrible disaster.
Mm. So you would rate that as one of your better or worse memories? Well,
look, I mean, it's interesting. It's I take a very positive view about what we were able to do there as a team. It was a primary care-based response, and in terms of how we worked together, we were a small team, and we saw some dreadful things, but we all pulled together, and that's very important, I suppose, in terms of preventing mental health consequences, which links to tonight. The worst experiences are kind of similar. We, just like any other health system, we deal with tragedy on a regular basis, and for me, sometimes that can be very intense. When we're dealing with people who are killed or seriously injured in battle. Now, for many of our health people, that's a very personal and up close and intimate experience.
Yeah, absolutely. That is clearly, I can imagine, one of the most difficult things. I'm interested though in I guess more and more the Defence Force is being deployed to humanitarian missions, and I can understand the kind of both the good aspects, but also the horror that sometimes inevitably accompanies those kinds of missions. But
yeah, look,
anyway, yeah,
you see people who are in the depths of human suffering, but even in there, some of humanity's most amazing traits can come out.
Yeah, absolutely. Okay, well, thank you to all our panel members for that, and I think we can all see what an esteemed group we have and how lucky we are to have them with us tonight, and it's going to be a great discussion. I should have put that slide on before. Let me talk briefly about the webinar series. This is part of a series. DVA have commissioned MHPN, the Mental Health Professionals Network, to plan and produce and deliver a series of 6 webinars in the broad area of mental health and the military experience. And of course, the purpose of these is really to try and build capacity among clinicians around Australia in their work with veterans. Tonight, as we said, is the first in that series, and we're going to explore the impact of military culture and military experiences on veterans' mental health, and we'll be looking at that with regard to Tom in a minute. The next webinar in the series is in late October, and that one will be on the recognition and treatment, and particularly evidence-based treatments of PTSD or post-traumatic stress disorder. And I know that that is an area that many of you as participants are very interested in, so do make a note of that date when it comes up, and join us in that, and we'll go into PTSD in much more detail. And then the later ones will look at a number of other things such as anger and substance use and family issues and so on. I should say that I've been extremely impressed by the number and quality and the range of questions that have been submitted by participants even before we started in the build-up to tonight. And so we're going to have a very interesting discussion kicking some of those issues around. I did just want to note, though, that some of the questions were about specific disorders like PTSD or substance use. We'll get onto them if we can tonight, but please bear with us if we don't get to all of them. And we will certainly, you can rest assured, we will cover them when we go to those particular topics in the coming months. So I have to tell you about some ground rules, if I can work it. Okay, so we do have some ground rules which are up on your screen at the moment. So I just will read it to you quickly. To help ensure that everyone has the opportunity to gain the most from the seminar, we ask you all to consider the ground rules, be respectful of other participants and panelists, as I'm sure you will, behave as if it's a face-to-face activity. Post your comments and questions for panelists in the general chat box, which you'll see at the bottom of your screen. If you need help with technical issues, then put a post into the technical help chat box. And do just be aware of the fact that all the comments that are posted in the chat boxes can be seen by everybody. So please keep the comments on topic and appropriate. If you find the chat distracting, you can hide it by clicking the small down arrow at the top of the chat box. So that will take it out of your screen if you want to. But if you are happy with it being there, then you would use the general chat box to send questions to us or to make comments as we go along. Your feedback is very, very important. So at the end of the webinar, you will be asked to complete a short feedback form, and I'd really encourage you to do that because it's very important for us to get some kind of evaluation about how things are going. Okay, so let me just talk very quickly about the format for tonight. Basically, the 3 panelists that you've just seen will spend 5 minutes each, and I'm strict on time, so they're only going to be allowed 5 minutes, to talk about Tom's case from their perspective. And so that means both from a disciplinary perspective in terms of a psychiatrist, a psychologist, and a GP, but I would like them also to talk a little bit about their perspective in terms of an ADF perspective, a DVA perspective, and a community perspective. So we'll have those 3 5-minute presentations, and then we'll open it up for a general discussion among the panel members and between the audience and the panel members, and that will take up the bulk of our time tonight. In terms of the learning outcomes, as again you can see they're on the screen there. Through a facilitated panel discussion about Tom, participants will better understand the meaning of military culture, and in particular mental health at home, on deployment, and or leaving or transitioning out of the Defence Force. The second dot point is, of course, that you will be more confident in responding to veterans' mental health needs. And I would see the second dot point flowing from the first, that if we're going to treat veterans' mental health needs effectively, we do need to have an understanding of the context from which they're coming, a little understanding about the military experience and so on. And then our third learning objective is to increase knowledge about evidence-based treatments and practices when we're treating veterans with mental health conditions. And certainly we will try and look at that a bit tonight, but it is going to be a particular topic for later webinars. So, I hope you've all had a chance to read Tom's case. We're going to be looking at Tom's case tonight. It's not an unusual case. I think Tom represents a kind of amalgam of many veterans that we've seen over the years. And tonight we're going to follow Tom's path through his military life cycle, if you like, through his time in the military, through his transition out of the military, and in his where he is now in trying to adjust to life as a veteran. And we'll try and explore some of the psychosocial and mental health challenges that Tom will have faced through that life cycle as he progresses from recruitment through to life as a veteran. As we said, we're going to focus particularly on understanding the context and the culture and how that's impacted on Tom, how that's influenced his well-being and his mental health, perhaps in good ways as well as bad ways. Okay, all that being said, it's time to hand over to our first panelist, and I'm very pleased again to reintroduce Duncan Wallace and hand over to you, Duncan, to do your brief presentation.
Thanks very much, Mark. I'm going to start by talking about the general health care that Tom has received to inform you about health care in the ADF more broadly through his example. So as you know, Tom has sustained an ankle injury, and initially he'd be seen by a medic attached to his unit about that injury and then seen by a medical officer. Now he's probably at a forward base, and so he might have to be referred to a larger base for imaging and physio. And if he needed a specialist assessment, he might have had to have been flown to another town like a major hospital that was in Kandahar. Now, infantry people have to walk, and they carry very heavy loads, 40 to 60 kilograms of body armour and weight and ammunition. And so they have to be able to walk. So if they can't do that, then they would be given light duties, such as in an office. And in Tom's case, he was sent home early, and that would have quite a significant impact. He didn't get to finish his deployment. He would leave his friends. He'd be very disappointed about that. And there'd be the additional loss of allowances and tax benefits that defence people receive whilst they're overseas. When a defence member completes a deployment, all ADF members will undergo a medical screen and a physical examination, and they'll also have a return to Australia psychology screen. And this consists of a number of screening tests and a one-to-one assessment with a psychologist. And if it turns out that they do require immediate mental health care, then that is arranged as soon as they return to Australia. Further down the track, they'll also undergo a routine follow-up at the 3 to 6 month mark, and that follow-up test is called the post-operational psychology screen. Now, when somebody returns back to Australia after a deployment, if they were having mental health problems, and sometimes they're reluctant to disclose those because they're keen to get home and spend time with their family, and they're worried that they're going to be seen as being weak. Mental health problems can sometimes be seen that way in defence, and they're also worried that having a mental health problem might have an adverse impact on their career and possibly their promotion prospects. Now, we know that in Tom's case, he's had a significant injury, and we know that this can be a risk of later developing conditions like depression and PTSD and other anxiety disorders. So that's a bit of a risk factor for Tom. And so when he returned to Australia, his ankle injury would be reassessed by a medical officer and then referred to imaging, physio, specialist care as required. Now, anybody with a significant injury like that would also be assigned a personal rehabilitation consultant, and they do a great job of coordinating their care and facilitating their return to work, and also liaising with their chain of command, who are their work supervisors. Now, somebody who sustained a serious injury may also have a downgrade in their medical employment classifications. Now, this is an administrative and medical process that allows members to continue to have access to their care, to appropriate medical care, and also lets their supervisors know what duties they are fit to perform. And it also prevents them from being posted away on deployment or to remote locations while they're in the middle of active treatment for a condition, which is obviously very important. Now, if a member is so unwell and suffering from such a serious injury they can't do any sort of meaningful work, then they'll be referred to their local Soldier Recovery Centre. This helps them to maintain their connection to the Army. They might do a little bit of physical training consistent with their injuries, their disability, and it means they have ready access to healthcare services on the base. Now Tom, because he's a veteran, both he and his family are entitled to a full range of mental health services through the Veterans and Veterans Family Counselling Service. Now those services are free of charge and they're completely independent of the ADF Health Services. In fact, the ADF Health Services might not even know that a member is receiving mental health care through this confidential and free service. Now, Tom's been off work for 12 months. He's an infantry soldier and he's been doing administrative duties because of his injuries. This would be a significant challenge to him as an infantry soldier. They're very active people, action-oriented, and this would be quite a change in how he saw himself. He'd be concerned that others, his peers, might see him as being weak or soft, and he too would be frustrated at his reduced physical abilities. Now, when a service person has had a serious medical or surgical condition preventing them from being fit to deploy for 18 months or more, then they're going to be referred to the Central Medical Employment Classification Review Board, and their fitness for retention in the Defence Force is going to be considered. If they consider they're likely to get back to work within a reasonable amount of time, then they'll probably be retained in the Defence Force. But if it's unlikely, then they're going to set a timetable for a medical discharge for that member. Now, as Tom's medical discharge approaches, he would be getting ready and would have contacted the Department of Veterans Affairs to notify them about his injuries and to enable ongoing health care, and if appropriate, perhaps receive disability payments depending on the level of impairment. He'd be encouraged to find a civilian GP and provided with referrals for ongoing care, a handover, and he'd get a copy of his entire medical record to take with him. Now, from a psychiatrist's perspective, looking at Tom's case notes there, his distress when he hears his daughter cries makes me think that might be an external cue that's reminding him of traumatic events that he's experienced in Afghanistan. And his wife's concerns, her comments that she's walking on eggshells and they're spending a lot of time away from home, leaving Tom back there at home by himself, means that, to me, that there might be a problem, significant problem with him having anger issues at home. Certainly Tom's insomnia, his restlessness, and his abuse of his wife's sedatives point to really significant sleep difficulties, and we need to obtain a detailed history of his sleep patterns, his use of sedatives and other drugs, and certainly alcohol. Now, the Medicare GP health assessment for former ADF personnel, I think it's a really good place to start for a patient like this if you're a primary care provider. It comes with a great PDF tool that prompts you to take a baseline detailed history for veteran just leaving defence. It's got specific questions on sleep and screens for distress, for K10 and PTSD, alcohol abuse, anger, and the item numbers, the Medicare rebate item numbers are listed there. So that's my spiel. Over to you, back to you, Mark.
Thank you very much indeed, Duncan. Yeah, look, there's a whole lot of stuff there that I think, I hope that we'll be able to pick up in the discussion, all sorts of key issues. I think, as you point out, Tom's had a couple of quite difficult transitions, hasn't he, in terms of, as you say, coming back from deployment without his unit, I think, can often be difficult. And then, as you say, transitioning out for a medical discharge must always be difficult. So, and then you also raise the issue of barriers to care, and I'm sure all of those issues will come up as we go along. So thanks for that, Duncan. Let's move on now and hear about both a DVA and a psychologist perspective from Steph. Thanks, Steph.
Okay, so with Tom, what we would like to talk about now, leading on from what Duncan talked about, was what does this mean for transition? And I think one of the key issues here is, what does effective transition look like? It's interesting, most personnel within the ADF now serve 7.5 years. A lot of people don't realise that, in fact, the average length is about, about a 7-year career. It is less for the people who actually, there's less that actually get out in retirement, about 20 years, like many of us in this group here today. But what that means is that it's really important, as these people are leaving quite early in their working life, that we make sure that they transition effectively and that they transition to make sure they have new meaning in their lives. I must admit, at the time that I transitioned, I was really lucky. I thought I was one of the lucky ones. I was leaving because I had a new opportunity. And when I first left, I had a friend grab me. He'd been out for a longer period of time, sat me down, had a coffee and said, Steph, this is going to be hard. It is actually hard when you've been in defence for a long period of time to transition out. Defence gives you a whole series of values and a belief system that you've got to readjust once you actually get out. You actually have to go through a period of saying, who am I now and how do I fit within these new work environments? Just to give you a feeling of what I mean when I say that, you know, there is a readjustment, the culture results in a readjustment. In defence, it's a very make it happen culture. So if you think about some of the examples that have already been given tonight, we told stories of going overseas, having to deal in a disaster situation, getting troops into an operational area. It is all about meeting the demands for people to be able to achieve what they need to do in their job. And if you don't make your deadline, then other people are at risk, or you don't achieve, you know, you don't get the disaster support where you need it. So people in defence have this real can-do mentality, which when you leave defence can actually be quite an adjustment as you go to jobs where, you know, the need, someone is not, their day is not going to fall apart just because you didn't make it to the meeting or meet the deadline. In defence, we have our own, they have their own language. So you leave defence and you're no longer surrounded by people that speak the same language that you do. Defence has a whole lot of meaning, and leaving defence and going from a situation where you are providing service, you actually have a whole feeling of contributing to something bigger than myself. To end up in a job, you know, where maybe what your main goal of the day is to earn the money so you can get to the next holiday, can be quite an adjustment difficulty. It's really important, therefore, for someone in Tom's type situation that he finds a way to find a new to live, to be and to contribute, and potentially through employment. As a result, DVA has actually started to, and Defence is actually bringing forward transition services, the ability to do vocational work. It used to be you had to do 20 years. That's no longer the case, to help with that transition process. Tom and his family has social connections, and he in his story talks about the fact that he wishes he could see his friends. The issue is often people on discharge will move to a new location, somewhere different, or maybe back to their family of origin. So they're no longer close to or regularly seeing their military friend. Even if Tom was staying in location and close to his military friends, that comes with a whole new set of challenges. Your mates are now still going on exercise. Your mates are still actually going on deployment. You're no longer part of the stories and the adventures that they're having. And that in itself can be very isolating, and you have to go through a bit of a grieving process because you're not part of the team the way that you used to be. You need to be, it's really important that we help Tom, and effective transition is when someone is aware of the support services to them. We're going to talk about this a little bit more in a moment, but one of our greatest challenges is that there are many support services, but making sure people are in touch with them when they need them is actually a huge challenge for us. Only 1 out of 5 people that leave Defence actually need the support of DVA. And as a result, 80% of people get out, they transition effectively, and they actually don't need DVA's involvement at that point in their life. I'm just seeing whether I can change my slide. I'm sorry about that. I've changed one too many. I'm with you now. So in Tom's case, he's already in touch with DVA. He's actually, because he would have had contact because of his injury with on-base advisors. But many people leave Defence and transition out to the broader veteran community, not actually knowing where to get support services. What I often talk about with people is, you know, I didn't pay any attention to my super payments, those letters that came, until I was actually leaving the Defence and I wanted to know how much money I would have. You know, I used to put them in a file somewhere. Similarly, if you're not actually experiencing problems now, you may have been told about the Veterans and Veterans Family Counselling Service, but if you haven't had a need to pay attention to that information, you won't remember it. And it may be a couple of months, 2 years, 3 years later when you have problems that you don't always remember that the service is there. It is why seminars like this, where we get the chance to talk to professionals about what is available, becomes so important.
I'm just keeping an eye on the time, Steph. We just need to keep moving along.
Yep. Tom will need to engage with rehab in order to keep his incapacity payments. So from a psychologist perspective, there is with Tom that we would definitely be wanting to get him into it for an assessment. The types of ways in which he could actually get this assessment would be through, sorry about the fact I'm not so good with changing the slides. He could actually go online at night and he could look at the ADDIE's website. He will be able to access treatment for anxiety, PTSD, alcohol or substance use by simply seeing a GP. He would then be given a white, basically the GP does the diagnosis, he gets a white card, and then we will pay for unlimited treatment based on clinical need for those conditions. Tom and his family, as already been highlighted, can access free support for both him and his family at any time through the Veterans and Veterans Family Counselling service. It's really important that he engages with the GP and the GP is aware of all the range of DVA services. Importantly, you'll see in your little folder down there that there's information not just for Tom to be able to look at on the ADDIE's website, but there's information for you guys as clinicians. This is only a brief introduction to some of those cultural issues I was just touching on. There are online training courses which take you through where people deploy, what deployments are like, and expand on those issues that I've just talked about in more greater length in online training on the ADDIE's website. The last thing I'll say is never forget the fact that Tom will have actually been very resilient at a number of points in his life. He was resilient enough to get through military training. He was resilient enough to do well on operations. Often as a clinician, what you're looking for is not to teach him new skills, but to remind him of the skills he already had and get him back in touch with his coping strategies. Thanks, Mark.
Great. Thank you, Steph. Thank you. It's clear that there's a whole lot of services there for Tom, and I guess one of the things we'll pick up in the discussion is about whether or not he can, whether he does access them, and perhaps what's stopping him accessing them. But some great stuff there, and I would particularly like to reinforce the comment you made about the fact that any veteran can get free treatment for PTSD, for depression, for anxiety, for substance use, without having to prove a service connection. And I know that's been around for a really long time, but I still think there are a lot of veterans and indeed a lot of providers who don't necessarily realize that. They should be able to get into treatment really very, very easily without having to go through any kind of fight about it. But anyway, thank you very much, Steph. Let's move on to our final panel member and welcome Isaac again to give us a GP perspective, but a GP perspective that's very much informed by Isaac's military background. Isaac.
Well, thanks very much, Mark. Look, a lot of the important points are already out there, so I get some of the easy bits in that relation. Look, I just wanted to start by talking about the generic ex-serving member, and then I'll come to focus on Tom himself, because as has already been pointed out with in Steph's talk, the average length of service is a bit over 7 years. So the idea that the ex-serving member will be someone who will be male and grey-haired is the first myth that's important to bust. So they can be young or old. They can be any gender. They can be very healthy. They could have resigned from service with a clean medical slate, or indeed they could have complex health needs. Someone like Tom has both physical and mental health needs to be managed. They could be of any degree of fitness. It's not like we can put people through a car wash or a service and get them back to 100% before they separate. Now, there's been a bit of discussion about this one here. They may not identify with the term veteran, and I must say, even I find that a little bit challenging, and it's why I've used the term ex-serving member there at the top. And perhaps that might be something we discuss a little bit more later on, Mark. I guess in sum, the ex-serving member could be like anybody else in the practice. So just a couple more specific points about the ex-serving member. They may have deployed on operational service. All of our panellists tonight have, but they may not. And that service could have been different kinds of categories. And warlike service we would know as operations such as Afghanistan, Iraq, or the early operations in East Timor. Non-warlike service such as the Solomon Islands or Bougainville. Humanitarian service we've mentioned already tonight, such as the tsunami disaster, earthquake relief, flood relief. and also service in Australia, such as the Vic Fires operations. Often when there's cyclones in the north, Defence personnel are mobilised on operation, a named operation, and events such as the Sydney Olympic Games, where there was an operation to cover that. Now, there's a link there on the slide that is useful for people who see ex-serving members, just to understand what the context is. That they'll say, "Oh, when I was serving on Op Slipper." Oh, what's Op Slipper? Well, Op Slipper was the Middle East and Afghanistan. They might, and it's okay to ask, "Oh, tell me what Op Slipper was." Now, let's just talk a little bit about health literacy. Bear in mind that the stereotypical Australian defence person joins straight out of school, goes to one of the recruit schools or to the Defence Force Academy or one of the officer training schools. And we pick up in defence their healthcare from that point. And often these guys and girls would not have even had their own Medicare card. Their healthcare would have been managed by their family, and they won't necessarily have a great deal of understanding of what it means to go to a GP or a civilian provider off their own bat. So it might take a little bit of explaining the first time that you see someone like Tom, and part of that might include a little bit of education about how billing works. I would encourage all the GPs out there certainly to please consider bulk billing ex-serving people, but obviously you're at liberty to make your own decisions about that. But certainly if there is going to be a gap to pay, it is worthwhile to get that out there at the beginning and just explain that. Look, how things work. Specialist referrals. While we're serving members, the doctor decides to refer us to a specialist. They write the referral, and the next thing that occurs is we receive a text message that says, you're seeing the surgeon on such and such a date, here's the address and the phone number. They won't understand that actually, the GP will write the referral, but they need to make the phone calls and book in and go and turn up. So simple things like that about how things work and a non-judgmental approach is always worthwhile. Just a little about general demeanour. You will find that ex-serving members are very respectful of health professionals, and that comes out of the fact that health professionals in the military are almost all officers. They are used to calling the doctor or the psychologist sir or ma'am if they're an enlisted person, and they're certainly used to a very collegiate professional relationship if they're an ex-serving officer. Now, understand that sometimes there will be a little bit of language that slips out, and that is probably just part of the culture. If that makes you uncomfortable, it's okay to correct it and just to say, look, I'd prefer it if we kept the language as clean as possible. That's okay. So we'll move on to my next one there. The ex-serving member has had comprehensive health care, so I talked about that already, including this thing called the preventive health exam, which some of those online who have military experience might know as a medical board. This is a little bit like an occupational medical exam. It's a top-to-toe physical exam and some preventive discussion as well. The e-health records that Defence uses now are NETA compliant. That doesn't really mean a great deal yet in terms of my health record, but it will in the future. It is likely that they'll come with a CD-ROM of that record, and at the very least for the comprehensive patients, it is part of the plan that they will come with a handover for you. As I've mentioned about the e-health record, they've also got a documented and comprehensive vaccination history that is the envy of world travellers. They may even have hold of their yellow book, their international certificate of vaccination, and certainly for those that are seeking to travel, questions like have you had a yellow fever vaccine will often be met with yes, I have. So they're right to go to Africa and the Caribbean.
They're conscious of the time. We need to just keep things moving along, Isaac.
No worries, Mark. So we've already talked about the post-discharge assessment, thanks Duncan. Those protocols are available in both Medical Director and Best Practice, and as I've mentioned, ex-serving members are familiar with that kind of examination. I guess if there's one thing I'd like you to take from tonight is that it's very worthwhile to ask everybody that comes in, have you ever served in the military? A lot of ex-serving members won't volunteer that, but if you do, you'll extend an opportunity to open a discussion with them. Just a couple of points about Tom. I think you've all read the case. I think you really do need to develop a trust relationship, and the earlier you can do that, the better. He may need some direction in relation to his health. That's okay. He's used to it. But importantly, he needs to be told. The why of any intervention. Military people have a concept called commander's intent. It goes purpose, method, end state. Purpose is why. You don't just say take that hill. You say my purpose is to defeat the enemy, and I'm going to do that by taking the hill, and so on. He's likely to be informed by some reliable but also sometimes very unreliable sources. Dr. Google is somewhere in the middle of that scale. He certainly continues to have access to services and supports that we've already discussed, not just VVCS but also a number of ex-service organisations and associations. But he needs to and can be called for bad behaviour if it occurs. He is used to a team-based approach. Certainly within the Military Health Service, it is a general practice-centric approach, but a number of multidisciplinary players are involved in that. And also consider, in this case, you might be the family's GP. Is there a competing interest, and how might you manage that? And I think peer review at the professional level within the practice is probably a good suggestion there, but we can discuss that some more. He's likely on a reasonably generous pension, and again, we can discuss that some more if you like, Mark. And that's all I have.
Excellent. Thank you very much, Isaac. Much appreciated. And thank you to all our panellists for some very thought-provoking comments there. We're going to open it up now into a broader discussion. And so I'm going to encourage the panellists to jump in whenever they've got something to add. And I've asked them to feel free to disagree with each other, because the bottom line is these are not easy questions. These are difficult issues, and there often isn't a right or wrong answer. And so having different perspectives, different approaches is often very useful. I want to just do a couple of quick ones first, if we could get them out of the way, because they've been asked a few times by our participants. I should just say, I don't know if you've noticed, but we're up to 870 participants, which is an astonishing number of participants. Wow. And I'm absolutely thrilled that we've got so many. So, but several of them have actually just asked for clarification of something you raised, Isaac, which I think is a very important question, which is about exactly what a veteran is. Because I'm right in saying, aren't I, either yourself or Steph, that just because the person has served in the ADF does not necessarily mean they're a veteran. Is that right?
Oh, Mark, happy to take that one.
Yeah, do, Steph, yeah.
Yeah, look, it is a little bit confusing because according to legislation, the acts on which give compensation, a veteran is described as someone who has actually had operational service. A challenge we've had in the department, though, is how do you just explain the broader veteran community? So ex-serving and serving personnel is the inclusive term and more correct term for anyone who served. But in reality, what we talk about is the broader veteran community, as in anyone who's had ADF service. Increasingly, we are looking at eligibility for things like access through non-liability being open to anyone who has served. So I suppose that a little bit of the tension comes from what we know from the definition we require for compensation, but the broader desire in the health service delivery area for mental health in particular, where it doesn't matter what your service, you don't have to prove a cause. We will treat you before you even have to put in a claim. And that is just for anyone who served, whether or not they went on operations or not.
Good. Okay.
So it is complex because there's two different areas with two different definitions.
Yeah. Yeah. Okay. Now,
someone could be, Mark, someone could be a veteran, but they don't necessarily identify with the term. someone could be ex-serving, but they're not necessarily a veteran. It is absolutely confusing, and so I guess for the practical so what is that if we use the term ex-serving, we as health professionals won't get into trouble, and then the veteran stuff is enshrined in the legislation and the rules.
Yeah, I think it's a very good point, isn't it? And I think in the general community, I think there's often a perception that veteran means an old digger in a blazer with medals across his chest kind of thing. And the reality is, of course, that our veterans today, most of them are very, very different to that. And I think the point you made, Isaac, that for a lot of them, the term veteran, they just don't relate to. It doesn't describe them. So, as you say, ex-service is perhaps a better way of going. So I want to take the discussion, we don't have as much time as I'd like, we should extend this by an hour or more, but anyway, I'd like to take us quickly, sort of chronologically through, if you like, and just talk a little bit about what happens in the ADF, talk about transition, and then talk a bit, especially, I guess, about where Tom is now. But it does strike me that it looks as though Tom has probably had a kind of fairly steady decline over the last 12 months that he was in the ADF. And clearly he got good treatment for his ankle and good rehab and all that kind of stuff. I guess I'm wondering, just checking it out there, about whether you think that the people working with him would have had any awareness about mental health, about the risks of Tom developing depression or whatever, firstly. And secondly, whether you think Tom would have been able to stick his hand up and ask for help. Would the culture kind of allowed that? So I know there's a lot there, but can I just chuck it out to the panel and get someone to jump in?
Yes, Mark, I'm happy to take that. There's certainly a lot of education programs to raise mental health literacy amongst serving members. That happens very, very frequently. As to whether he would be comfortable about presenting, that's still an ongoing problem. Obviously, those mental health literacy programs are designed to allow people to come forward, and there's a lot of emphasis described, particularly say at annual mental health day, to encourage people to seek treatment early. But we know from our research that people still are very concerned. There's a lot of barriers to care that relate to how their peers will see them and their concerns about whether they'll be able to progress in their career, and or whether if they do have a serious mental illness, whether they'll end up being discharged. So they're very commonly held. We see them in the Defence Forces for other countries as well. It really seems to be part of the military experience to have those concerns.
Yeah, I mean, and they're not entirely unreasonable concerns, are they, in terms of the potential impact on the career? I guess, we have to be realistic that it may have an impact.
Yes.
But the first part of my question, and perhaps Isaac might want to pick up on it, is whether or not the general health staff, the medical officers and the physios and whatever, would their antenna be up for mental health issues? Would they be sort of looking for it, do you think? Yeah, just put it out there. I wonder if they would.
Yeah, look, I think it's very hard not to these days. And, we talk about stigma. Well, as I reflect on my early career as a junior doctor in defence, when we hadn't even deployed to East Timor back then. We didn't have the systems that we have now. We didn't have the comprehensive mental health teams, multidisciplinary teams with psychologists, social workers, mental health nurses, alcohol, tobacco, other drugs workers. We basically had access to uniformed psychologists and whatever we could refer to in the community. So the system has come a long way. In terms of the training that is provided, a lot of it is actually provided through Duncan's organisation. It is extraordinary the amount of training that's available to our general health staff now, and we all benefit from that. Does that extend to eliminating concerns that people might have in terms of presenting for mental health care? Well, I don't think it does 100%, but that would be the same in community practice. I think it's an incredibly courageous step for anyone to usually come into their GP and say, I want to talk about my my mental health, or I'm feeling a bit down at the moment.
I think it's a very important point, Isaac, and we've got good data, haven't we, that suggests that the uptake of mental health services in the veteran community is actually much higher than it is in the general community. So you're quite right. You know, civilians with depression and anxiety and PTSD, they're not going along to get help either. So it's certainly not exclusively military personnel.
But I guess I would make the point that everyone has a story, civilian, military, and the risk is that we read the newspapers and watch the sensational TV shows, and you get the impression that to have a diagnosis of a mental health condition, you need to have served in the special forces, in the outside the wire, very kinetic parts of warfare. Well, you know, as most of the audience would appreciate, to have depression or PTSD is just part of the human condition and the experiences that we have wherever they occur.
I think it's a critical point, isn't it, Isaac? Exactly. And we need to fight any suggestion that in some way, unless they've been exposed to the really nasty stuff in the special forces or whatever, that somehow they don't deserve to have a mental health condition. It's patently absurd, but I think we need to fight that sometimes. So if we talk about Tom, you know, every effort has been made in defence to rehabilitate him and so on, but the reality is he's not going to be fit to deploy, and therefore he has to be medically discharged out of the ADF. And this surely is a very, very tough kind of process for him. I guess, you know, several of you raised this in your presentations, but I wonder if we need to comment any further on the differences between discharging of your own volition because you want a career change and discharging because you've been medically discharged when you didn't really want to go. Does anyone want to comment on that? It's presumably much more difficult.
Yes, yeah, happy to comment on that one, Mark. Obviously, a planned discharge, the end of their contract, or they're approaching 20 years service, that's something they will have thought about for some time, discussed with their family. A medical discharge is very frequently much more of a surprise to them. It's unexpected. It leads to a major change in their plans, and as I've emphasised also, it has a bigger impact on their identity too, because it means a major change from being active, and if they are suffering from the acute phase of a major mental disorder with like depression or PTSD, yes, we are going to limit their access to firearms and explosives, and which it takes them away from their support group, their unit, the cohesion and protection that they get from that. So that it has a number of problems as they begin that transition. So often they're unsettled, and things have changed very significantly for them as they approach their medical discharge. Often they're in a bit of conflict with defence about the timing of that. They don't want to go, or they want a bit more time to undertake training courses, which are often very generously arranged for them. But still, there can be a bit of conflict about the timing of the discharge. So, and often their engagement in defence can finish with a degree of bitterness that it didn't happen according to their timetable.
Well, just to sort of take that a little bit further, I mean, to state the obvious, I guess we would have put a lot of time and resources into training Tom up to be a soldier, and I suppose the question is whether or not we're putting enough time and resources into training Tom to be a civilian, and of course that's particularly true for someone with a medical condition like him, but more generally as well. Do you think we're putting enough resources into that process? I know you mentioned briefly stepping out, Steph, so you might want to comment on that, but well, let me put it out there. Are we doing enough to help people adjust back to civilian life?
Mark, happy to step in there, because this has been a real focus of change at the moment. Is we had acknowledged the fact that people were slipping through the cracks. You know, a massive change that's happening in this space is we actually need to have claims and problems that people have had during service dealt with much earlier. So for the first time ever, one of the problems to get past DVA not knowing who has problems afterwards is that when people come into recruit training, they'll actually be put in contact with DVA. So the hope for the future is that as people go through their military service, a lot of the claims process, injuries will be recorded, DVA will know about them. You don't have to go through that whole prove years later process. But in Tom's case, there are a number of options, and I think this is where clinicians actually have a lot to offer, because Tom is going through a grieving process, and it's really important he doesn't get stuck in that grieving process, because if he gets too stuck, and it's sort of in the case study at the moment, there's a real risk here at the moment that he'll be looking back so much backwards that he won't look forward. And there is a place for, you know, organisational psychology, vocational rehab. Tom will be going through a lot of rehabilitation. He will be going through a psychosocial assessment. He will be put in touch with a rehab provider. The challenge is often getting people to, you know, they've got to grieve, they've got to be ready to move forward, and that's where clinicians actually have a major role to play. Stepping Out is a group-based program, and often being able to go and do that program, it's run through the Veterans and Veterans Family Counselling Service. So anyone who's getting out, you typically do a transition seminar, and you'll do that just before you leave. And in the transition seminar, they'll recommend going to do with a partner or family member stepping out. I think, again, the trouble is there are good services there, but you don't actually always know as you're leaving that you're not going to cope. You know, in Tom's case, he might think, I've had enough. This is, I'm over it. I just can't wait to get out the other side and move on and be away from the military. So he might bypass offers for things to help him that would actually help him. And I think that's where clinicians also have a role at encouraging people to engage where they can.
I think it's an important point, Steph, because I hear entirely what you're saying, but the fact is that a reasonable number of people do slip through the gaps and somehow don't get picked up with the systems and services that exist there. I was interested in your comment, and I'm just going to be a little bit provocative here, because you said that only 1/5 of veterans need DVA services. I think it's true to say that only 1/5 of veterans access DVA services, but I don't know that I would necessarily, well, whether we know for sure that more than that perhaps need them but are not accessing them. So I suppose a general question about, are we doing enough to stop people slipping through the gaps? And are we doing enough in terms of assertive follow-up? And I know that's really difficult because, as you rightly point out, Steph, a lot of people now have got to the end of their career and that's all they want to do is to get out. But do you think we should be doing more, either any of the panel, in terms of assertive follow-up for people like Tom?
I think I'd like to answer that with a question, because I think there's a significant percentage of people, when they leave the ADF, they actively opt out and reject any contact or follow-up by DVA, and Steph might comment on how much that is. And I think a lot of people do actively turn their back on it, and they feel that I'm going to be better when I get away from defence. They've got this idea that that defence is causing all their problems, and unfortunately the problems can sometimes continue with them, and that they feel that they'll be right once they move away, get a civilian job. Unfortunately, sometimes problems can have a delayed onset, like with PTSD, and the problems begin to emerge, say, a year or two after leaving defence, and that it might be some time before they finally accept the need to get some care. And by that stage, they've had no contact with DVA, and they have to start the process right from scratch.
So let's pick up on that then. So if we think about Tom, and I thought in your presentation, Duncan, you outlined very nicely some of the warning signs that we should be picking up with Tom. So from memory, you know, he's avoiding stuff. We know that he's potentially got some intrusions. He's got some bad memories, certainly, that are triggered. We know he's irritable. We know he's got sleep disturbance, hyperarousal, and so on. He's got problems with self-image. We know that he's potentially losing one of his primary sources of support in terms of his wife. So there's a lot of warning signs there. And I guess I might ask you, Isaac, from your perspective, because he's come to see you, he's come to see his GP, and he wants some medication, what you would see as being the next steps for Tom now. And I'm interested in whether you're going to give him a script for his sleeping meds.
Gee, that's a tricky one. Look, I think the first thing is to make the situation safe, and you know, he's likely to have booked a 15-minute appointment, and clearly needs more than that. So it is about making a rapid assessment about whether you're going to make people wait in the waiting room for longer, or ask him to come back later in the day. I don't think you can let the sun go down on a presentation like this. You know, we need to assess his risk of danger to himself or others. We need to ask all of those risk assessment questions. We need to be considering the risk factors for suicide that are controllable, because clearly that's the worst thing that could possibly happen here. And then we need to be working out what the plan is. I mean, we don't know what other supports he has in terms of social supports and safety nets. We're not sure if he's connected yet with the local DVA services or ex-service organisations or the associations from his previous serving units. So understanding the history is going to be very important.
Yeah.
Secondly, I guess it's a decision about if we decide that there is something that requires immediate management. We're in Townsville. Townsville has a tertiary mental health service available at the Townsville Hospital, which is fabulous. It also has private psychiatry available. It's very well served. So I guess we're very lucky in that regard. But then also you have access as a GP to advice from our specialist colleagues on what to do next and what to talk through. But you've also got access to your peers. And sometimes, in any difficult situation, a prescribing decision, a decision about whether someone needs an urgent referral, an involuntary referral, and so on, can benefit from a quick discussion with the colleague next door. So I think that outlines my next steps.
Okay. Okay.
Mark,
good.
I'd love to add a little bit there. So for the GP then, someone like Isaac, he then has a couple of choices. If you decide that, look, okay, he's a moderate risk today and I want to get him into care, one of the questions that came up in the forum, the general chat forum, was, well, do I send him through non-liability? Non-liability will allow you, the non-liability healthcare would allow you to put him into a private hospital. It will allow you to pay for medication. It will allow you to access any clinical treatment service, say for his depression, if you're thinking you've got depression or PTSD. The other services you've got, so you've got a whole set of services there, and you could also refer to allied health under non-liability, including social work. You've also got the option, if you don't know a good referral point, if you don't know a good psychologist that you think, oh look, in my network, I'm not sure who's good with veterans, you then use the Veterans and Veterans Family Counselling Service, because it has nationally 900 clinicians attached to it, but all those clinicians get support and training in military mental health issues. So it sort of gives the GP a couple of options. If he needs inpatient care and you give him access through you get him the non-liability white card, you can immediately actually pay for the private health care that he might need. Or alternatively, if you don't know the service providers, I'd be looking to VVCS. The most important thing here is not to forget his wife and his kids.
Okay. And we're going to pick up on family issues in one of the later ones, but I'm very glad you mentioned that, Steph. And the clock is just ticking away on me, and we're just not going to get through so many of the questions that people have sent in, which I think are great. Steph, I'm going to ask you to answer this one in literally just one sentence, really. Some of the panelists have been asking when they should go to, or the veterans should go to DVA and when they should go to VVCS. Is there a bit of advice you can give people about that very quickly?
Very quickly, Tom would actually have already DVA compensation because he's already getting capacity payments. DVA non-liability is, like I just said, when you're looking for the broader spectrum of mental health support. VVCS when you are looking for clinicians who are connected to a network of people who are supervised to deal with veteran mental health.
Great, thanks. And we've got less than 1 minute before I'm supposed to wind up the general discussion. I'm going to introduce one of the biggest topics there is. So forgive me, and it means that the panelists have got like 30 seconds to answer it each. But I guess that one of the things we're all aware of, and one of the things that's been raised by many of the participants through the course of this evening, is at least a perception, even if it's not true, a perception that the process of putting in a claim to DVA is a very onerous and difficult task, and that sometimes, particularly around mental health issues, it can become quite adversarial. So I just chuck it out there and just see if anyone's got any suggestions for clinicians or veterans about how they can make that process a bit easier or any comments about it, but you've only got 30 seconds each, I'm afraid.
Duncan here. I think it is a difficult process. The last request for a report I got from DVA was 24 pages long. The questions are often complex. You have to support the patient through the process. Most veterans have pretty much a love-hate relationship with DVA, and I tell them it's a 12-round fight, and you have to keep in the ring swinging and follow the swings and roundabouts and appeals, and to try to get the best result possible for them.
Okay, good advice. Very good advice.
I guess, Mark, I would just add that you can get support from various advocates. The RSL is a good starting point for advocates that help. You don't need to use lawyers to get through DVA. Those that are still serving, there are various means that we use to encourage people to put in their claims early, and there's support available both on base, and people can access the advocates that I mentioned already.
So, Mark, I can't stress enough the fact that the non-liability mental health treatment is a simple form. You make your diagnosis, they'll be as a GP, and they'll get the white card. So treatment is become very streamlined. In terms of the longer-term support for incapacity payments, things that come through compensation, because there is a major reform process going, they're taking what is a paper-based system and they're turning into an electronic one. That will not happen overnight, and it is important that clinicians actually just help their clients be realistic, because otherwise they'll just end up frustrated. So there are moves in place to improve it, but the best thing the clinician can do is exactly what Duncan said: be a support, and help them not give up. Make sure that they keep going, especially with mental health, when we know that people can sometimes get depressed and maybe step away from doing what they should do to get the entitlements that they should have.
Quite. Okay, good. And just to pick up, I know you've made the point about 10 times, Steph, but it's such an important point. I'm glad you have, really. Our first responsibility, really, is to get these people help, isn't it, first and foremost? So the fact that we can do that easy, there's no reason why we have to put up barriers. There are no barriers, really. It's just awareness and so on. So getting people into treatment quickly and easily, facilitating those pathways, I think is important. And I think Isaac's point as well about the ESOs, the ex-service organisations, are really well set up for helping people to get their claims. In fact, some would argue they're slightly too well set up in terms of getting claims through. But they do a very good job, and they support their veterans through. So do encourage the vet to have a chat to their ESO. I'm going to do a very quick whiz round of the panel now and just ask if people have any closing comments or take-home messages. Before I do, I did just want to comment on one of the participants' questions where the question was why we don't have a veteran on the panel. I'm actually the only person who's not a veteran on the panel. All the three other panelists are very definitely veterans, so we should make that clear. But let me go back to the panelists then, just for a 1-minute summary of any final comments that you'd like to make, or any sort of take-home messages. And I don't mind the order, really. Do you want to start with you, Duncan?
Yes. So I'd just like to make a point about time and the sedatives. Using benzodiazepines in patients with post-traumatic stress disorder, I think it's inadvisable. The concern is obviously about dependence potential, but more particularly because of the risk that can increase symptoms of anger and aggressive behaviour. American clinical practice guidelines are firming against their use for people with particularly combat-related PTSD, and a recent meta-analysis is really starting to show that benzodiazepines are associated with no improvement or worsening of overall severity of a lot of PTSD outcomes, and shows that in fact it's associated with an increased risk of developing PTSD. So I think if you're going to use benzos, use them for a short period of time. You need an exit strategy, and please don't use them on a long-term basis.
Yeah, thank you, Duncan. I'd love to have had a long discussion about that one, actually, because I do think that often, well, I don't know, but maybe perhaps a little bit too often when people go to their GPs, they're given benzos, and as you say, it might not be the best thing in this situation. Okay, next, sum up, Stephanie.
Very quickly, there are some great tools for clinicians. You can check them out on the At Ease Professional website. They include a really great suicide ideation management app, which is to manage someone you think is at risk between sessions. Importantly, that app will put the veteran in touch with the 24-hour veteran support line. The last piece is never forget the family. Tom's wife probably also needs support, and she would have free and unlimited care through VVCS for that.
Great. Thank you, Stephanie. And Isaac, final comments?
Well, look, I think it's just extraordinary how many have dialed in tonight, and that just indicates how important an issue it is. So thank you very much to the team at MHPN for putting it on. Look, I guess my point with Tom is that, and with all ex-serving personnel, is that trust is critical, and establishing that relationship is really important. But once you do form that relationship, you will find that loyalty is incredibly strong. They will keep coming back to you, and concordance with your advice is likely to be high. I guess be aware of all of the contextual features, the background, ask lots of questions, do the research. I encourage you to go to that website that I put up about ADF operations. Attending these sorts of webinars is also worthwhile. But if you're unsure, ask. And sometimes if you've got a question about being in the military, the best person to ask is the ex-serving person themselves. They certainly appreciate you showing interest in their experience. One of the resources, and I'm not sure if it's in the Dropbox there, the GPs will be familiar with Australian Family Physician. The edition from March this year, March 2016, contains some articles on veterans' health that are a useful starting point. It's open source, so you can Google that online. It's the Royal Australian College of GPs journal, Australian Family Physician, March 2016.
Great.
Thanks, Mark.
Thank you very much, Isaac. Thank you. And I'm sorry to have to rush everybody. But look, it does seem, the take-home message does seem to be there are a lot of resources out there, both for clinicians and for veterans. We didn't get a lot of time to talk about the apps and things, but they're all there on the ATE's website. And so there's a whole lot of really good apps and a whole range of other stuff. So there's a lot there. Check out those. And I think our challenge is about facilitating pathways to care. We didn't get as much time to talk about those barriers and about what's stopping veterans from accessing care as I would have liked, but we can't get through everything. The care is there, and it's about helping to facilitate those pathways. So we're going to need to wind up. If anybody is interested in facilitating face-to-face networks of mental health professionals in your area, MHPN can support you to do that. So if you just provide your details on the feedback survey, they can help you out with that. Can you please make sure that you complete the feedback survey that's going to pop up when you log out, and attendance certificates will be emailed to you. You'll receive an email with a link to online resources, and put this in your diary. We can't put it in your diary because we haven't got a date yet, but coming up at the end of October, a webinar like this on PTSD, which I think will also be very interesting, and we can see the future topics there on the slides also. So at this point, I think that's all that I have to do, except, of course, to thank everybody, to thank all the participants. As I say, I'm absolutely thrilled by the numbers of people who've been with us tonight, and I really hope that you found it valuable. I've certainly enjoyed it, and I'd like to thank our panelists very much indeed for their help, and we'll look forward to talking to everybody at the next webinar in late October. Thanks to everyone. Bye-bye now.